Hello, good morning, good afternoon, and good evening. Today's video is going to be a continuation of the discussion on liver function tests. Today we are going to be focusing on AST, also known as aspartate aminotransferase, where it comes from and what it means. Origin and function. AST, formerly called SGOT. SGOT stands for serum glutamate oxalate transaminase, present in both cytosol and mitochondria, which is clinically relevant as mitochondrial injury. Example, in alcohol-induced hepatitis, disproportionately increases AST levels. Tissue distribution of AST. AST is abundant in liver. What is the clinical significance? AST is released with hepatocellular injury, especially when mitochondria are involved, as in alcohol-induced liver injury. AST is present abundantly in the heart and is elevated after a myocardial infarction. Moderate amounts of AST is present in skeletal muscle as well and elevates in rhabdomyolysis, myositis, trauma, and after seizures. Moderate amounts are present in kidneys, brain, pancreas, and RBCs. That is why you see significant elevations in AST after multi-system injury or hemolysis. Half-life and enzyme kinetics. Half-life of AST is approximately 17 hours, whereas half-life of ALT is approximately 47 hours. AST is located in the cytosol and mitochondria, but ALT is present in the cytosol only. AST is less liver specific, but ALT is more liver specific than AST. Interpretation of elevated AST. AST to ALT ratio. AST to ALT ratio is less than 1 in non-alcoholic fatty liver disease and chronic viral hepatitis. The ratio is more than 2 in alcoholic hepatitis due to mitochondrial injury plus B6 deficiency. AST to ALT ratio is more than 5 in Wilson's disease and advanced cirrhosis. And the ratio is more than 1 in cirrhosis if it is advanced. Causes of AST elevation. Mild to moderate elevations, 2 to 5 times the upper limit of normal, is typically seen in NAFLD, chronic hepatitis B and C, medications, and alcohol use. Marked elevations of more than 15 to 20 times the upper limit of normal is seen in acute viral hepatitis, ischemic hepatitis, and toxin-mediated injury. Disproportionately high AST is seen in alcoholic hepatitis, rhabdomyolysis, trauma, hemolysis, and myocardial infarction. Special clinical scenarios. Marked elevations in AST with normal ALT. Think of muscles like rhabdomyolysis, statin-induced myopathy, or muscle trauma. AST, ALT, and GGT elevation suggest hepatobiliary disease. Isolated AST elevation plus hemolysis, think of hemolytic anemia or microangiopathic processes. The ratio more than 2 to 1 is strongly suggestive of alcoholic liver disease, especially if GGT is also elevated. If CK is elevated with AST but ALT is normal, then think of muscle rather than liver. In severe liver necrosis, both AST and ALT can fall despite worsening prognosis due to hepatic depletion. In that case, check INR and bilirubin for synthetic function. The following are the references.